Start then.
Yeah, I can give you a quick introduction. Thanks everybody for coming in. I'm Chris Flanders. I'm the Executive Director of the Hawaii Medical Association. Thanks for letting us be a part of that. Quick introduction of Dr. Wade. He's presently the Legislative Liaison for the Hawaii Radiological Society and a fellowship trained radiologist with more than 20 years of experience in women's imaging. Today, we'll present the latest American College of Radiology information on screening, patient prioritization based on risk, patient education, and improved outcomes. So, Dr. Wade.
Well, thank you. As you said, again, my name is Loris Wade, and my background is in women's imaging and mammography. I'm currently a partner with Hawaii Radiological Associates. I'd like to welcome everyone to a discussion on the breast cancer screening toolkit. During this talk, I will touch briefly on the history of mammography, current United States Preventive Services Task Force screening recommendations, and the medical community response to those recommendations. I would also like to discuss current thought on breast cancer risk assessment and an ongoing paradigm shift in how we are approaching breast cancer screening. Finally, I would like to briefly discuss basic tools of the trade to include mammography, ultrasound, and MR. In order to understand where we are, it is important to understand where we have been. Mammography has its roots in the early 1900s. Pioneers such as Solomon were essentially using breast fluoroscopy to create their images. As can be seen on the left, even large cancers were not particularly conspicuous. However, these pioneers significantly advanced technique, positioning, and equipment design. Essentially, an idea was waiting the technology. The age of pioneers was followed by the age of technical progress. This era spans from about 1960 to the mid-1980s. The era's hallmark was the development of zero mammography by Dr. Wolf and the Xerox Corporation. Zero mammography produces a photoelectric image on a metal plate, generated by a photon beam using a long exposure and a relatively high radiation dose. An example of a zero mammography image is noted on the left. Using this modality, Wolf was able to classify many of the subtle signs of breast cancer. The era of technical progress was driven by two big events. In 1973, a landmark study performed by the Health Insurance Plan of Greater New York demonstrated a clear and statistically significant decrease in cancer deaths in women offered screening. Then in 1974, First Lady Betty Ford was diagnosed with breast cancer, and her candor immensely heightened public awareness of breast cancer issues. These two events served to accelerate a developing modality. 1970 saw the invention of intensifying screens which lowered radiation dose. 1974 saw the introduction of the MLO view. 1976 saw the introduction of wire localization for surgical excision of disease, and 1977 saw the introduction of magnification views. All of this progress was reflected within the ACR by developing ACR policy toward mammography, as reflected in the 1985 American College of Radiology introduction of BI-RADS standardized reporting, and in 1986, the ACR Task Force on Breast Cancer initiation of the first accreditation programs. The era of technical progress was followed by what has been termed the era of transitions. This era began in the late 1980s with the introduction of film screen mammography. Film screen mammography used breast compression, breast immobilization, a collimated X-ray beam, and improved film technology to form high-resolution images. This technology also resulted in faster image confidence outside imaging itself. In 1991, the National Institute of Health established a priority to invest in and develop digital mammography. In 1992, the federal government passed the Mammography Quality Standards Act, creating a uniform imaging standard for all facilities. In parallel with this, there was scientific development, including 1995 landmark study by Stavros showing that ultrasound can accurately characterize breast cancer. The 1990s also saw the nascent development of breast MRI. In 2000, the FDA approved its first digital mammography unit, and by 2014, 93% of facilities were transitioned to full field digital mammography. And this transition continues with the ongoing adoption of digital breast tomography. As a result of decades of work in science, by 2009, population screening rates were approaching 60%. Just when everything was going great, a wrench was thrown in the works. In 2009, the United States Preventive Services Task Force entered the fray. The United States Preventive Services Task Force is funded, staffed, and appointed by the Department of Health and Human Services in Washington, D.C. It is an independent panel of experts in primary care and prevention. They systematically review effectiveness and develop recommendations for clinical preventive services. The United States Preventive Services Task Force evaluates evidence to determine whether medical screenings work for adults and children without symptoms. The task force assigns a letter grade to every screening study offered within medicine. They also attach recommendations and suggestions for practice. They categorize tests as follows. A grade A test is recommended as having a high certainty that net benefit is substantial. A grade P test is recommended with the idea that it has a high certainty that net benefit is moderate, or there's a moderate certainty that the net benefit is moderate to substantial. I apologize for the word salad, it is not mine. Grade C examinations are a different story. In these types of tests, clinicians may provide the service to select patients depending on individual circumstances. However, for most individuals without signs or symptoms, there is a likely only a small benefit. And then grade D tests are things that the task force just basically doesn't think should be done at all. In 2009 and in subsequent updates, the United States Preventive Services Task Force upended traditional research-based recommendations regarding breast screening. For women ages 50 to 74, the task force recommends biennial screening for women ages 50 to 74. That's every 2 years, and this test is assigned a grade of B. For women ages 40 to 49, the United States Preventive Task Force states that the decision to start screening should be individualized. In this age group, screening is assigned a grade of C, i.e. the benefit is considered to be small. For all women greater than 75, the task force cites insufficient data and does not assign a letter grade to screening for mammography for women over the age of 75. With respect to all women, the task force cites insufficient data and does not support digital breast tomography for screening at all. With respect to women with dense breasts, the task force cites insufficient data and does not support secondary or supplementary screening. So why does this matter? Why is it as important? The Patient Protection and Affordable Care Act was passed in 2010. The language of the bill eliminates patient cost sharing as a barrier to screening only for tests that are given grades A or B. As such, if the United States Preventive Task Force recommendations are followed, insurance plans would not be required to cover annual mammography in women ages 40 to 49 under the ACA at all. The federal government has responded to fairly large public and medical community outcry through legislation. This legislation protects access to life-saving screening in the age group 40 to 49, most recently with the Protecting Access to Life-Saving Screenings Act, which is now current through 2020. As such, the Preventive Service Task Force has upended traditional breast care screening recommendations because no one is particularly following them. Various organizations have responded with their own recommendation sets. This recommendation proliferation has resulted in confusion as to which recommendations to follow. The first set is what I call a traditional screening regimen. This is American College of Gynecology, the American College of Radiology, and the National Cancer Network, NCCN. This group recommends starting screening at age 40 with annual mammography, continuing until the patient has a life expectancy of 5 to 10 years. The second set is what I call the compromisers. This includes the American College of Surgery. As of a few years ago, the American Society of Breast Surgery and ASCO. They decided that it was appropriate to start screening at age 45, then continue to age 54, then reduce screening to a biennial or every other year process, and then continue screening until the patient had a life expectancy of 10 years. The third set are professional groups that have accepted the United States Preventive Task Force recommendations on a whole, at least that this is the stated policy of these organizations. And this includes the American Academy of Family Practice and the American College of Physicians. Basically, this group recommends starting mammography at the age of 50, stopping at the age of 74, and only performing mammography every other year. I would like to note that at this point that the American Society of Breast Surgeons have recently revised their recommendations. I will discuss these later. The American College of Radiology response to recommendation confusion is best voiced in their recently released October 2019 Mammography Toolkit. This response is literature-based and designed. The American College of Radiology Toolkit basically seeks to answer 4 questions. What is the risk of breast cancer in women? Does mammography save lives? When should mammography start and how often should women be screened? What are the risks and benefits of mammography? Question number 1, what is the risk? Breast cancer is the most commonly diagnosed cancer in women in the United States. In fact, in 2019, it is estimated that over 331,000 women were diagnosed with breast cancer. Stated differently, about 12 to 13% of women will be diagnosed with breast cancer during their lifetime. That is approximately 1 in 8 women. What is the risk? The risk is relatively high, and breast cancer is relatively common. Question number 2, does mammography save lives? This is my niece, Abby, and my niece, Abby, really wants to know the answer to this question because her maternal grandmother presented with a palpable mass on self-exam in her mid-40s. She had never been screened up to that point. And unfortunately, Abby's grandmother succumbed to metastatic breast cancer before she was born. This is a chart of the age-adjusted breast cancer mortality rate over time. As you can see, the mortality rate was nearly steady up till 1989, maybe slightly increasing to that point. 1989 is considered the birth point of modern mammography with the advent of film screen techniques and improved access to screening. Since 1989, hundreds of thousands of lives have been saved by the use of screening mammography and new developments in breast cancer treatment. Since 1989, the breast cancer death rate has decreased by more than 40%. How is this determined? There are basically 2 types of research protocols designed to demonstrate the efficacy of breast cancer screening: the randomized controlled trial and observational trials. Randomized controlled trials were generally performed using zero mammography early in the history of mammography. Observational trials are now the norm. This is a summary of the 8 randomized controlled studies performed to date. The graph compares the death rate of invited to screen patients to an unscreened population. Essentially, the unscreened patients are the control. This is why we can no longer perform this type of study, because we have to invite everyone to screen. The 2 Canadian national screening studies are outliers and seen as the MBSS studies. They both demonstrate a higher death rate in the screened group. This has been attributed to poor imaging and poor patient grouping, which compromised the study. For example, women with breast cancer or with symptoms were often placed in the screening group. Even including the flawed Canadian NBSS studies, the combined data shown at the bottom demonstrates a 24% reduction in mortality in the invited to screen group. Randomized controlled studies proved screening mammography decreases mortality from breast cancer. However, the magnitude of mortality reduction has been underestimated. As discussed previously, some of the data is polluted due to study design, but included anyway. This is why we have observational studies. Observational studies compare women in a given population who had screening mammograms to those who do not. These studies assess the impact on women who actually receive a screening study rather than those who are invited to screen but declined. While less strict parameters leave room for selection bias, the studies are more practical for assessing efficacy of screening. This concept is important because institutions like the United States Preventive Services Task Force have used statistics derived from randomized control studies to devalue screening. Essentially, they're using the lower mortality rates of RCTs compared to observational studies to justify their actions. Observational studies, on the other hand, are very large studies. These are predominantly service-based screening programs as exist in Europe. These service screenings refer to centrally organized large-scale programs with standardized protocols, centralized databases, and reliable outcome monitoring with tumor registries and use modern equipment. This is the combined data from 10 currently published European observational studies as of 2012. This is selected by the ACR because Broders et al. Essentially combined the data of these 10 observational studies. Broders' data demonstrated a combined weighted decrease in mortality of 49% in women actually screened versus unscreened women. Question number 3, when should mammography start and at what age? To screen or not to screen, simple statistics provide an answer. 1 in 6 of all breast cancers are found in women ages 40 to 49. The 10-year risk for being diagnosed with breast cancer in a 40-year-old woman is 1 in 69. About 1/3 of years of life lost from breast cancer are in women in their 40s. And women in their 40s typically develop more aggressive cancers that can be more difficult to treat. The randomized controlled trials proved that screening mammography saved lives in all women ages 40 to 74. Each choice has a consequence, each consequence a destination. It's one of my favorite quotes. The goal of screening regimen is to find cancer as early as possible and save as many lives as possible. Based on decades of evidence, the American College of Radiology advocates women of average age undergo screening annually beginning at age 40 and continue for as long as they are healthy. This has cut breast cancer deaths by more than 40% and decreased the years of lives lost significantly. Some organizations have issued alternative guidelines promoting less frequently screening women over a shorter period of time. We showed some of those guidelines earlier. So it seems reasonable to ask what happens if those recommendations are followed. As I said before, each choice has a consequence, and the American College of Radiology has tried to show what those consequences are. This is a chart of variant screening regimen outcomes. It outlines results if less aggressive screening guidelines are followed. The first line is data referable to American College of Radiology guidelines and clearly demonstrates the greatest reduction in risk of dying, the largest number of lives saved, and the greatest number of life years gained for a population of 100,000 women. This is the regimen embraced by the American College of Radiology, the Society of Breast Imaging, and the National Comprehensive Cancer Network, as well as the American College of Gynecology. The second and third rows are regimens currently embraced by a number of medical professional societies, several of which are very important in the primary care of women. The lowest line reflects adherence to the United States Preventive Task Force guidelines. And as you can see, the reduction in risk of dying of breast cancer is only half is that recommended by ACR. The number of women whose lives will be saved is less than 2/3, and the number of years of life years gained is also less than 2/3. To my mind, we are losing substantial benefits by less aggressive screening strategy. This chart outlines similar data in a different way. The chart shows the distribution of years of life lost due to death from breast cancer by age of diagnosis. 43% of total years of life lost due to breast cancer is in patients diagnosed at age 49 or less. Delaying first screenings until age 50 deprives some of the most vulnerable women of the greatest benefits of screening. Question 4 is, what are the risks versus benefits of screening? On the left, we have a chart of the time course of 100 women who undergo screening. Out of every 100 women who get a screening mammogram, 90 will be told that their mammograms are normal. 10 will be asked to return for additional mammography or ultrasounds. Of those 10, approximately 6 will be assured that their mammograms are normal. 2 will be asked to return in 6 months for a follow-up exam, and 2 will be recommended to have a needle biopsy. And of those 2 who undergo biopsy, only a percentage will have a positive biopsy. This time course of how patients move through the system is important because the United States Preventive Services Task Force includes many of these steps as risks in their analysis of whether screening mammography should be offered. Specifically, false positives and anxiety are presented as risks by the United States Preventive Services Task Force. However, from our standpoint within radiology, we consider the recall rate to be uncommon at only 10%, and biopsy to be rare at 1 to 2% per year. We also consider that short-term anxiety will resolve without long-term detrimental effect. And we also anticipate that digital breast tomography promises to reduce false positive rates for many women with dense or heterogeneously dense breast tissue. So what are the real risks of a screening program? Again, the American College of Radiology has sought to provide an answer. The risks of screening mammography are essentially threefold. First, there is a radiation dose risk, and this is considered to be very low and is lowering with further advances in technology. The second risk are accuracy risks. This includes false positives, which can result in extra tests, biopsies, or anxiety, and false negatives, which can result in delayed treatment. Dense breasts is a completely separate issue and can result in further false negatives. The third and final risk is overdiagnosis and resulting overtreatment of diffuse carcinoma in situ, or so-called precancer or stage 0 cancer. These factors must all be balanced, however, against the more than 40% mortality reduction, and must be balanced as well with dollar cost. But these are systemic issues. At the end of the day, a patient, what she really wants to know is what is her risk and whether she should be referred for mammography. The American College of Radiology recommends annual mammography screening starting at age 40 for women of average risk of developing breast cancer. Our recommendation is based on maximizing proven benefits, which include a substantial reduction in breast cancer mortality afforded by regular screening and improved treatment options for those diagnosed with breast cancer. For defined categories of risk, the American College of Radiology makes further recommendations with respect to higher risk patients. I think I went one slide too. Basically, the American College of Radiology makes recommendations based on risk category and patient age. This is a relatively traditional approach to patients with specific risk factors or histories. This approach is rapidly changing. I seem to be jumping around a little bit here with my slides. I apologize. The change is basically initiated by the American Society of Breast Surgeons. In its position on screening mammography published in early 2019, the American Society of Breast Surgery changed the paradigm. Basically, they start with the risk assessment and then make their recommendations. I expect that similar guidelines will be forthcoming from the American College of Radiology, but for now, surgeons are taking the lead. As I stated before, traditional screening starts with clinical breast exam and an invitation to image. This is basically the process which the American College of Radiology advocates to this point. However, tailored screening is going to change the paradigm. Tailored screening begins with identifying women who may be at a higher risk than the general population for developing breast cancer. This is basically a summary of the American Society of Breast Surgeons' position on screening mammography. Basically, they advocate for women aged 25 or greater that they should undergo a formal risk assessment for breast cancer by their physician. These women, then basically women with an average risk of breast cancer should initiate breast screening mammography at the age of 40. However, women with a higher than average risk of breast cancer should undergo yearly screening mammography and be offered yearly supplemental imaging. This screening should be initiated at a risk-based age. Screening mammography should cease when life expectancy is less than 10 years. These recommendations are summarized on a decision chart. So first, one determines whether a woman is of average or higher than average risk. Factors such as breast density, genetic testing, and family history are considered. Please note that alongside breast density, genetic testing, and family history, they've added predicted lifetime risk greater than 20% by any model. This is new. This is the formal risk assessment. This risk assessment and this decision tree then drives imaging decisions. To get an understanding of the quote, individualized risk assessment, one starts with a few basic definitions. First, a hazard is something that can cause harm. Breast cancer is technically a hazard. Risk assessment attempts to determine a patient's exposure to a given hazard. Therefore, risk is essentially the combination of hazard and exposure. Decisions about risk, however, can be inaccurate. They should not be subjective or based on emotion. Even physicians can underestimate risk. According to a JAMA article published in 2017, only 80% of physicians started recommending annual mammography at the age of 40, and only 88% of physicians were recommending mammography screening to women age 50 or greater. So my question is, are some physicians ignoring or underestimating the risk? Similarly, patients can either overestimate or underestimate the risk. Some patients think that sharks are everywhere. Specifically, 2/3 of patients overestimate the risk when asked, and 9 out of 10 underestimate the age of onset. Half will underestimate the 5-year survivability if they're diagnosed with breast cancer. Some patients, however, don't think there are any sharks at all and decline screening altogether. Traditional risk assessment as of 2000 was fairly simple. It was clinic-based and was based on personal and family history. In the early 1990s, genetic testing was very limited. The BRCA gene was only discovered in 1990. Myriad Genetics was founded in 1994, and a economically available or purchasable product was only available by 1996 and suffered from significant high cost. The known breast cancer risk factors as of 2000 are summarized in this chart. These include gender, age, family history, various prior pathology results, and also include the very limited genetic testing that was then available. The physician would then make a subjective assessment of the degree of risk of the patient in front of them. As of 2020, one could say that the more things change, the more they are the same. Risk factor assessment still includes genetic factors, prior biopsy results, and family history. However, there are now the major addition of breast density on mammogram. Both heterogeneous dense tissue and extremely dense tissue are considered to be risk factors for the breast of cancer. This is an evaluation that's based on mammography. Basically, we look at the mammogram and we assess how much glandular tissue is present. And when we categorize the mammogram as fatty replaced, scattered, heterogeneous, dense, or extremely dense. From left to right, you can see increasing degrees of glandular tissue. Dense breasts are now known to be an independent risk factor for breast cancer. We formerly thought that dense breasts just hid breast cancers and that was the risk. However, dense breasts themselves are now known to be a risk factor independent of the density of the tissue, meaning dense breasts are associated with a higher degree of dividing cells that can mutate. Heterogeneous dense tissue is associated with a 1.5 times risk relative to the general population, and in extremely dense tissue, that risk is increased by 4 times. But how do we get from simply listing risk factors or assessing breast density to risk factor assessment? The answer is in the use of breast cancer risk assessment tools. It's important to note that these tools do not tell a woman whether or not she will get breast cancer. They only tell her a percentage chance that she could get breast cancer. Within models, risk factors are assigned a relative risk for developing cancer by the age of 80. These risks are then stratified and weighted within the model. A model determines the percentage chance a woman will develop invasive breast cancer over a specified time period. Sample models include Tyrer-Cuzick, the Gale model, Penn 2, Klaus, and the BCSC model. Again, all of these are works in progress and are undergoing continued refinement. How are these risk models to be used? Well, Tyrer-Cuzick is a representative risk assessment model. It provides personal risk by assessing the chances that one is a mutation carrier or more likely to have a genetic predisposition of getting breast cancer. Validation studies as of 2019 showed this model was one of the 2 best models tested at predicting a 10-year risk of breast cancer. This model also provides 5-year, 10-year, and lifetime risk for breast cancer. The model then goes on to make specific recommendations. If the lifetime risk is over 10%, the Tyrer-Cuzick model advises consideration of formal genetic testing. These tests are now more readily available and are becoming much more affordable over time. If the lifetime risk exceeds 20 to 25%, the Tyrer-Cuzick model advises consideration of supplemental screening with either MR or ultrasound. And ultrasound more often because MR is often either not available or declined. The model uses a number of risk factor inputs to generate its assessment of risk. These include age, weight, height, menarche, parity, menopausal status, and estrogen replacement theory, the genetic status of the patient, prior biopsy results, and many others. But how would this apply to an individual patient? Basically, if you have a 45-year-old premenopausal patient with no significant past history of her own, she might present to your clinic because her mother had breast cancer, now diagnosed at age 70, and now she's worried. She's basically asking, what is my risk? This particular woman might not have had a prior mammogram and has no known additional risks. When we put in all the risk factors into the computer software that we just touched on previously, the IBIS model generates a risk estimate. After entering this particular woman's information, her 10-year risk for breast cancer is calculated at 4.4%, with the comparison population risk at 2.3%. No great surprise, her risk is elevated because her mother has breast cancer. This woman's lifetime risk of developing breast cancer is 22.9%, with a comparison population risk of 12.3. So this enables a clinician to kind of frame what this woman might have looking forward. So let's say you send her for a mammogram. You get back a report, and thankfully it's negative, but the report includes the note that she has heterogeneous dense tissue. If you go and feed that back in the model, her lifetime risk now falls back to 19.7%. If she were extremely dense, the risk would rise to 28.4%. Again, this enables you to reinforce the need for screening in a woman who has a negative mammogram. But the model is able to tell you roughly where this woman's risk lies. Going back to the American Society of Breast Surgery recommendations, we can now put the additional information into the table. We now know that this patient is at higher than average risk. She has a predicted lifetime risk exceeding 20% or approaching 20% based on the mammography results. So in this woman, we can recommend annual mammography with 3D being the preferred modality. And we can offer access to supplemental imaging. MR would be preferred when it's recommended by their physician, but the fallback position would be to offer a supplemental screening with ultrasound. So where is the ACR on this supplemental screening or this imaging with higher risk women? Well, to be perfectly honest, the American College of Radiology is in catch-up mode relative to the American College of Breast Surgery. Prior to 2018, the American College of Radiology use of supplemental screening was dictated by American College of Radiology appropriateness criteria, which are listed on the right. The decision whether to pursue these additional studies was simply left to the referring clinician. In 2018, the American College of Radiology changed its stance and made supplemental screening recommendations for higher than average risk women. These recommendations basically still start with a known risk factor and incorporate patient age. The recommendations encompass women with genetic-based risks that are known, a prior history of chest radiation, personal histories of breast cancer, or a specific diagnosis on a prior biopsy. The imaging recommendations include various combinations of digital mammography, digital breast tomography, and MRI. Finally, the American College of Radiology does state that all women should be evaluated for breast cancer risk, and I believe this is a move towards the use of formal mathematical risk assessment tools. All of these recommendations are still made with a caveat. The real life use of MRI and screening is not caught up with the recommendations. So what tools do we have? The imaging toolbox basically is comprised of digital mammography and DBT, directed and whole breast ultrasound and breast MRI. Full field digital mammography and tomosynthesis is our primary tool. Mammography and DBT can detect 20 to 65% more invasive breast cancers relative to traditional screening alone, and can reduce callbacks by 40%. The FDA, as opposed to the Preventive Task Force, has approved digital breast tomography as superior for women with dense breasts. So even within federal government, there is some conflict. Digital breast tomography uses a moving X-ray tube to image the breast, essentially creating relatively high resolution stacked images in a single plane. The value of DBT is relatively easy to understand. On the right, we have a MLO view from a mammogram using a traditional technique. On routine MLO, which is now on the left, we see heterogeneous dense glandular tissue and no detectable mass or cluster. On the right, we have a DBT image from the exact same women on the exact same day. And on the DBT, we can now see a spiculated mass with architectural changes. As a next step, we would advise ultrasound. Whole breast ultrasound essentially comes in two types. Traditional ultrasound is handheld, and handheld ultrasound is currently performed at HRA. However, HRA performs handheld whole breast ultrasound at most of its facilities. The alternative to this is an automated machine, which basically compresses the breast and takes a single ultrasound picture of the entire breast and then reformats it in 3 dimensions. This technology is available, but not commonly used at this point. Automated whole breast ultrasound also has higher reproducibility and is not operator dependent. It requires less MD time and tech time. And I do think that eventually this technology will become more widely spread. The final tool is MR, and on the right we see a list of the basic indications for performance of MR, which can include anything from elevated lifetime risk, genetic mutations, to evaluation of people with tumors. So basically, I'd like to close with a couple of quotes. The first is by Richard Bach, and it is, "Argue for your limitations, and surely enough, those limitations are yours." If we pursue less aggressive screening strategies, more women will suffer from breast cancer and mortality rates will rise. The second quote is also from Richard Bach. "You are never given a wish without also being given the power to make it true. You may have to work for it, however. Everyone listening wants to reduce breast cancer mortality. We have the tools and we are backed by the science. However, we must continue to work on behalf of our patients to ensure widespread access to these life-saving studies." And with that, I'd like to transition to questions and a legislative session where we can talk about some of the more recent developments in terms of screening, and perhaps even get into our current interest in screening inequities between different ethnic groups.
Hi, this is Scott Grosskreutz here, and Loris, I just wanted to thank you for a really informative talk. I've heard it the second time, and I'm continuing to learn from your very detailed review of where we're at. In Hawaii, we're kind of a unique state, and one of the interesting things about Hawaii, of course, is a very diverse population where, if you count Asian and part Asian women, we're probably about 2/3% of the population has got some Asian ancestry. In Hawaii, Native Hawaiian women have the highest mortality and incidence of breast cancer. We have about 18 and 19% of our breast cancers occur before age 50. And when breast cancer occurs early, it most often happens in women of Japanese ancestry. Hawaii has the 5th highest breast cancer incidence in the country, and that incidence is increasing every year. But we have a relatively low mortality, which we feel is due to women in Hawaii traditionally participating more with mammography. And so with that being said, we've got challenges because Asian women tend to have denser breast tissue. And of course, that's one of the reasons that we were pushing so hard to get full field digital mammography available in our state. So those are some of the background issues. We have Ms. Zara Khan in the audience today, and I hope she can say a few words, but Zara has published some fascinating articles raising the point that for Asian, Hispanic, and Black women, they are more likely to have breast cancer at an earlier age, before age 50, and that if clinicians follow the U.S. Preventive Task Force's guidelines, then they're going to miss many of the cancers and many of the fatal cancers in minority women. So that's of importance. And given those challenges, what do you think we can do, either clinically or legislatively, to address those?
Well, I think the whole USPSTF guidelines have been carved around a false sense of risk. Because when we look at every number and we carve it to suit a certain agenda, we begin to lose focus of the very simple fact that, first of all, 1 in 6 breast cancers are diagnosed in the 40s. That's a simple fact that every common person can understand, and begs the question, why we would not continue mammography annually in the 40s. In addition,
I'm in a conference. This is Dr. Grosswright. I'm in a conference. I need to get back to my conversation.
in addition to that, I think some of the ethnicity data is missing in the task force guidelines. But also for white women, 23% are diagnosed in the 40s. So I think a lot of these measures have been taken to basically reduce costs, and they're devaluing the lives of all women. And I feel like Dr. Wade's lecture was really helpful in going through the data and again, sort of validating that point, the number of people and the percentage of women who are affected in the 40s, I thought was really interesting.
So I don't know what people can see, but so I mean, you know, Zara raised an interesting point, and I was doing a literature search on some of the papers that have come out. And in point of fact, when we're there, a lot of this work is being done in Southeast Asia, which is obvious, you know, not an area of the world that many people in the United States are particularly fond of. But there's an important paper that came out of Iran and another one that came out of Kurdish or Iraq, both of which are showing substantial peaks in incidence of breast cancer in women that are, you know, in their early 30s and late 20s. And so in some parts of the world, screening regimens are beginning in women as young as age 25. In the United States, Washington, D.C.'s strategy has essentially been to lump everyone together. You know, and we can, you know, a discussion as to whether or not that's intentionally racist is probably for another day. However, I did think that that there was a salient quote in a recent letter put out by Sahil Stapleton, who I believe is at Massachusetts General, and basically his statement to me was illustrative of where we should be going within the American College of Radiology and screening as a whole, and that is that culturally sensitive care begins with culturally sensitive science. And we should constantly examine whether scientific findings can be generalized from the majority population to minority populations. Zara, in her recent published article, pointed out that there are racial disparities in how screening regimens are applied. This has been in the medical literature for 15 to 20 years, and the response has been, you know, basically crickets. And so I do believe that we need to move to risk-based screening because that will encompass some of the data that's coming out within the Black community, some of the data that's coming out within the Asian community, a lot of the data that's coming out of the Southeast Asian community. Because while the data still supports that the ethnic group that sees as a whole the largest lifetime risk may still be Caucasians, the greatest risk for developing early or premenopausal cancer, where we can have the greatest impact on quality of life, may be in other ethnic groups where larger numbers of patients are seen at younger ages. And so I think that the true value in some of the risk assessment tools that are coming out will be when we can incorporate some of this ethnic data into those tools and then be allowed to then make an individualized decision as to whether to offer screening or not.
Laura Scott again here. We've got it's kind of an exciting time in Hawaii. We've got some real synergy going forward. the HMAs and the Hawaii Radiological Society are talking about these issues. The other player that's come out has been the University of Hawaii Cancer Research Center, which has provided some very good research on these issues, on the incidence of breast cancer, the effect on different minority populations. And they're starting a statewide tumor registry where they're going to gather data from anyone who will participate. We hope will be every mammography screening center in the state. And they're going to basically use, they're coming up with some breast cancer risk model assessment tools that they feel are basically optimal for our particular population. And they'll be taking the mammography data from these different centers and basically using AI to calculate breast density and come up with risk assessment numbers. And so we hope that this is going to be something that's going to improve the risk assessment for women in Hawaii. And one of the big problems, of course, with determining risk assessment, for people as recommended by the American Society of Breast Surgeons and the ACR, is that most of the time that isn't done until people walk in with their mammogram. And my lifetime experience has been in over 25 years of breast cancer detection is that if you're screening someone on an annual basis, you will find cancers when they return for screening, but they're most often going to be localized cancers that are typically node negative, and those women have very good prognosis. Where you see women walk in the door with large cancers and metastatic adenopathy, where the cattle's already out of the barn. Those are the folks that are either coming in for mammography, like, haphazardly every 3 to 5 years, or they've never been screened before. And those women, of course, have a much worse prognosis. So can you educate us a little bit about the bill that you're writing for legislative introduction this year?
Right, I don't know whether people can see it. So basically, can people see that? Basically, we've written a bill which we hope to present to the legislature later this fall. And basically, the bill acknowledges that there are significant issues with the United States Preventive Services Task Force guidelines. And our basic proposition is that Hawaii shouldn't be protecting or not protecting its women based on what Washington does or does not do. That the state has the ability to step in and protect the Ohana and the women of Hawaii. So basically, our preamble basically discusses some of the issues with the United States Preventative Task Force. It touches briefly on some of the negative impacts that these recommendations may have on women of Pacific Islander ancestry and Asian ancestry. But the nuts and the bolts of it come down in terms of what we are specifically recommending. And that is that healthcare benefits or coverages should include some very basic needs for women in Hawaii. The first would be a formal risk factor screening assessment at or above the age of 30, informed by any of the readily available risk factor modeling tools. We've kept the language non-specific because these tools are evolving, and horse pulls into the lead, and then another horse pulls into the lead, and we think that decision as to which tool to use should be left to the physician. The second benefit or coverage that we think should be protected by the state would be a mammogram every year for any woman over the age of 30 deemed by a licensed physician or clinician to have an above average risk for breast cancer using that risk factor modeling tool. I think that this would enable, one, women to be able to get into a clinic and have a discussion with a physician and have it paid for. Two, be able to use the tool, and then three, have access to the imaging tools that are needed in order to make a diagnosis. Beyond the women that are known to have a mathematical increased risk, we think that this in the third bullet, that a baseline mammogram should be a right of any woman aged 35 to 39 inclusive. Just a baseline study. The science is still out there as to whether to continue annually, but I think that it's reasonable to get a mammogram on all women at age 35 more or less as a stopgap to protect against early breast cancer and women who otherwise do not find access to the system. The fourth caveat is that every woman over the age of 40 should have the right to a screening mammogram every year. If we put this into state legislation, then nothing that the federal government can do, or not do, as the case may be, would interfere with that. And then finally, any additional or supplemental imaging, such as breast MR imaging or ultrasound, as deemed medically necessary by ACR guideline, could be provided to those women if they have an order from a referring physician or clinician. So we think that these basic 5 healthcare benefits are essentially the way in which to protect Hawaii women the fullest from getting early breast cancer. The language also, I think, is helpful as we develop more information about at-risk women of varying ethnicities. Got
Well, thank you, Loris. Does anyone have any questions for Loris or for Zara about kind of the lecture or this plan of action that we'd like to proceed with this coming legislative session?
This is Leighton Pang. Can you hear me?
Yes, Leighton.
Hi, good lecture, thank you. I have a question from a primary care standpoint. Would this legislation convey any liability on the primary care physician if they were not to perform an individual risk assessment for a patient and then not order a mammogram for them, but later the patient was found to have a breast cancer?
If I may, I think that the legislation is designed to provide access to services if the referring clinician and the patient desire that access. I don't think that the legislation in any way, shape, or form, at least as I read it, because I wrote it, has any language whatsoever that drives, mandatory screening. At the end of the day, all of these decisions, even within the decision tool as put out by the Society of Breast Surgery, depend upon the patient-physician relationship and a discussion of the risk that patient has and the risks and the benefits of the imaging. At the end of the day, what technology I think would like to see is simply that conversation takes place. But but nothing in the legislation, whatsoever, would put primary care at risk. Say you have a 35-year-old patient on your panel, and you haven't seen them in 3 years, unless I think that there still needs to be, an initiation of contact by that patient.
Thank you.
Leighton, we're kind of hopeful that, so many times, especially our primary care colleagues, they've got so many things on their plate that they have to assess their patients for. And often these things are done without any compensation by insurance companies. And we're kind of hopeful that by putting this type of language in the bill that if a clinician elects to do breast cancer risk assessment, that's basically, going to be a funded activity, where they're provided, compensation for performing that vital service for the woman.
That would be helpful.
I would also note, if I may, that many of these risk assessment mathematical tools are available online. And so you could theoretically simply just make a link available to a patient. They could input their risk factors as they know them, because they haven't had any imaging or anything like that at that point. And then if they see something that they would like to discuss with the clinician at that point, I mean, that's potentially another avenue for entry. So what we're trying to figure out within radiology is, how do we capture young women between the ages of 30 and 40 who are at risk for breast cancer? How do we capture those people so that we find their breast cancers and get them treated at a point in time where that treatment has the best efficacy and the most value socially, emotionally, and in terms of quality of life for that patient?
So the second question I have, and I'm happy to yield if somebody else wants to ask another question. I didn't get to hear the entire lecture. Did you address breast MRI, particularly as a screening tool for patients with extremely dense breast parenchyma?
I didn't specifically address the individual modalities. The data is still out there. There's a lot of different ways that people are doing breast MR, all the way from fast protocols to full-fledged protocols with gadolinium and multiple sequences. So there's still there's such a wide range of how breast MR is still being done. There's not a clear winner per se. MR is still largely used as a tool to answer questions that are posed by either the mammogram or the ultrasound. Using MR as a primary screening tool or as a replacement for mammography is not something that we're seeing at this point.
What's your feeling though for patients who have extremely dense breast parenchyma?
For people that are in extremely dense parenchyma, we typically would describe that. The American College of Radiology and the American Society for Breast Surgery would state that when you get that report, an appropriate next step would be for the referring clinician and that patient to have a discussion of the mammography findings, and and convey the understanding that that mammogram will not be as sensitive for breast cancer as someone who has less dense tissue. At that point, MR is a reasonable thing to discuss and to offer as supplemental screening. That is a position that's taken by both the ACR and the American Society for Breast Surgery. And then you go from there. But there does need to be a discussion at that point. MR has its own set of false positives. There's a potential for findings that might not be breast cancer, but you need serial MR follow-up. And so my feeling is that it's a useful test. I've seen dozens of cases over the years where mammography and ultrasound did not identify abnormality where MR did in dense tissue. I anticipate that may decrease as DBT becomes more widespread. However, MR does have its role, and it is an excellent test for supplemental screening in women with dense tissue.
Morris, we have two additional questions that have come up in the chat box. The first was a comment that there was legislation in California to allow advanced nurse practitioners to interpret their breast imaging exams on their patients, and our thoughts on that. The other is from a surgeon who notes that, he sees many older women that in their practice that are presenting with breast cancers, which are still in very good health, and they're sometimes coming in without screening, and the cancer, of course, it's more challenging. And basically, as a breast imager, as things get more specialized in radiology, we often, even among radiologists with 4 years of residency training and usually a fellowship and then a lot of clinical experience, we kind of subdivide the work among ourselves with those who have got the most experience. Our APR and college, colleagues in Hawaii, we respect their work. They're critically important to the primary care team. I don't know that we have any call for people to interpret their own exams. I can't imagine that that would have a good outcome though. And so I would not encourage that. I'm still learning after over a quarter century of doing this. The second question is, maybe you could answer, Loris. What about the issue of the U.S. Preventive Services Task Force basically stopping breast cancer screening at age 74, especially in a population where many of our women are living into their 80s and 90s in good health?
I'll speak briefly to both questions. With respect to APRNs, I think that, physician extenders play a very important role in the delivery of medical care. Radiology, like most subspecialties, is suffering from fairly widespread shortages. So there is an inclination on people outside of medicine to look for alternative mechanisms of service. APRNs do have advanced degrees, but I wouldn't be completely averse to looking as to whether or not that could be done in terms of APRNs with screening mammography. But there should be very, very stringent criteria that they would have to meet to do that. And I would imagine it'd be like much else that we do. It would be under the supervision of an endocrinologist. But it's a very narrow path that needs to be pursued if you're actually going to make that happen. But I'm not completely closed off to the idea. With respect to imaging women, I look of advanced age. Okay, I did a program today on a woman that was 95 years old, and she was. So I am unprepared to ever concede the point that a 95-year-old woman should not get a mammogram. I think that's ageist and wrong. I like the wording that's been put out by the American College of Radiology and the American Society of Breast Surgery and a lot of other groups who frame this in terms of known life expectancy. A 90-year-old woman with no known healthcare problems probably going to live to be 100. Their life expectancy very well may be another 6 or 7 years, in which case I think it would be wrong. And I think it's wrong that the Preventative Services Task Force is trying to close the back door on older women. I think it's a conversation that should be had again between the physician and the woman as to whether or not the screening mammogram is worth doing. And it should be done in the light of whatever that woman's medical problems may be or aren't.
Can I say one thing?
Please.
Please.
And I do feel like it's really important to have cultural sensitivity data as a backdrop to how you approach the screening. Because as we're seeing, the race-related data showing us that a lot more women of different minority backgrounds do present in the 40s. So it's a bit misleading to guide them to delay their annual mammograms. And I was thinking recently of a South Asian PCP that I had gone to, and we were having this discussion informally, and she said, I have never in my 2 decades ever told anybody to skip a mammogram if they're of South Asian ancestry, because I always see women of South Asian ancestry. I'm South Asian, I'm familiar with that population. I constantly see that even without history and risk, they seem to present in the 40s. So I feel like building that racial sensitivity is really important. And in addition to that, I think once you do begin to realize that the current system is racially insensitive or unjust, then whether or not you intend to be racist, the system itself has some sort of systemic racial issue. So that needs to be carefully addressed, because I think, a minority might go to a PCP and be told that, well, you can start your mammography later, and that would lead her to the wrong decision if she in her 40s, really based on ethnicity as a risk factor, should go earlier. And separate from that, I also wanted to point out that not all whites are the same in terms of their risk. So I was really happy to see that Dr. Wade touched upon Iran, which is also a white population, where people present in the 40s more often so. And then Turkey, 47% of the women in Turkey are diagnosed under 50. And interestingly, 1 in 6 breast cancers diagnosed in Turkey is under the age of 30. And these are also women who identify as white. In Egypt, also a group that identifies as white, they're seeing that their presentation is in the 40s. And not all Blacks are equal. So West Africans have a far higher, people who have West African ancestry have a far higher rate of breast cancer than those from the East African side. In Nigeria, people are diagnosed in their 30s most commonly, and 40s. So the majority are diagnosed before 50. So it's just really interesting how we sort of get a global perspective on doing mammography. And I think with Hawaii being a very diverse state with a significant Asian background, I think it's something that we really can learn from that state.
I think many people may not be aware, even in Hawaii, that you know, from Japan and China and South Korea, there's a lot of studies there that although the overall rate of breast cancer incidence in those populations is lower, that their peak incidence is before age 50 again. And so again, I think it is certainly true that guidelines from the U.S. Preventive Services Task Force were promulgated based upon a data set that really was not set to optimize healthcare for large segments of our population. I think that's blatantly obvious, and for Hawaii to basically to follow those type of guidelines, it's going to have a very negative impact on the mortality of our women in the state of Hawaii. And so I'm glad that we're having this conversation, and I'm glad that we are talking to our clinical colleagues about this. And I very much hope that we can have a unified approach to the legislation going through and get this passed this session. Well, Laura, I want to thank you very much again, as well as Dr. Lisa Ignacio and Dr. Chris Flanders from the HMA for setting this up. Zara, thank you very much for joining us on the East Coast. You're looking at 1 o'clock in the morning your time, so we're appreciative that you took the time to share your expertise on this. And I'd like to thank our audience as well, and especially Dr. Wade. I just very appreciative of this talk. This is what I do for a living, and I learn a lot every time I hear you give this lecture. So thank you.
Thank you.